Hello, my name is Colin Coyne, and as Executive Director of Meta Global, on behalf of all of my colleagues, we'd like to welcome you to this important and timely video presentation. Meta Global is a global education service provider that seeks to connect practitioners, educators, and institutions to deliver a transformative model of healthcare education. We seek to improve the outcomes of populations by providing access to globally renowned faculty in a way that addresses present and future needs and through the lens of competency, character, and caring. The series you're going to view today addresses the essential topic of cardiac complications from COVID-19. The series is divided into 6 parts, which can be viewed individually or consecutively as one seminar. We'd like to thank our partners at Brookwood Medical Health Systems and Dr. Farrell Mendelsohn for providing access to this content. We hope that it adds to your practice. We hope you enjoy the presentations, and we particularly wish you continued good health.
Hello, I'm Dr. Donald Lloyd-Jones, President of the American Heart Association for 2021 to 22. I'm also the chair of the Department of Preventive Medicine at Northwestern University in Chicago. This presentation from the Cardiology PC Group in Birmingham, Alabama, on the CVD impact of COVID-19 should be very useful to you in your practice. I am so pleased that my former colleague from residency, Dr. Farrell Mendelsohn, was able to organize this series of presentations for your benefit. All the best to you and others in Asia as you continue to manage the COVID pandemic and the growing epidemic of cardiovascular disease. Enjoy the meetings.
And the truth of it is that it is really a challenge to put together a scientific talk because COVID has not been around for very long and there is a lot of flux with the science. So what I've decided to do, for us to get a better understanding of the impact of COVID-19 on heart disease and arrhythmias in particular, to start really at the very top and give you more of a global view initially and then move on to the specifics of cardiac arrhythmias. At times it almost seems that we've been battling the pandemic for many, many years, but in truth, we have been at it only for about a year and a half. The problem started in December 2019, as you all well know, with a group of 29 cases in China that were diagnosed with a very mysterious and very severe lower respiratory illness. The Chinese scientists were very prompt to identify a novel coronavirus as the reason for that illness. However, they were muzzled by the local authorities, and it took a full 2 weeks before the WHO was notified of this new virus causing these illnesses. So by January 2020, cases had spread to over 18 countries, and there was clear evidence at that time of human-to-human transmission as opposed to just animal-to-human transmission. So WHO ultimately declared a public health emergency of international concern. Truthfully, they should have called it the public health emergency of epic concern. But suffice it to say that the virus crossed oceans, and by February 2020, it was firmly in the United States. And at the end of the month, we documented the first community spread case here in this country. In March 2020, the WHO declared that COVID-19 was a pandemic. The virus was called the SARS-CoV-2. One of the only good things that may have happened over that period of time was that the scientists were able to do a full genomic sequence of the virus, and that really allowed the world to have a glance at what the code was and spurred the rapid development of vaccines that we are now all benefiting from. The impact of the virus on human suffering and human death has been staggering. The worldwide number of cases has exceeded 113 million, with over 2.5 million deaths. The United States has been one of the most severely affected countries with over 28 million cases and over 500,000 deaths. And remember that these numbers are in flux, they change every day, so as I finish this talk, these numbers will be already obsolete. This slide is a very good visual representation of the cumulative cases since disease onset. And the slope of the curve at any point in time is a reflection of the infection rate. And you can see that in the period between November 2020 and January 2021, we had a significant increase in the slope of the curve, reflecting the second surge that we all witnessed. SARS-CoV-2 is closely related to two other viruses that nearly caused significant pandemics at the beginning of the 21st century. MERS-CoV, or the Middle Eastern Respiratory Syndrome, was identified in Saudi Arabia in 2012. It had a case fatality rate of 35%. And maybe that's why it burnt out so quickly and only affected 2,500 people. 10 years prior, SARS-CoV was identified in China. Here, the fatality rate was 10%, and the total cases affected were 8,000. All these coronaviruses we're talking about are thought to have originated in bats with an intermediary mammalian species that was identified as camels for MERS-CoV, but not identified yet for SARS-CoV-2. We're all aware of the WHO team that's currently in China trying to figure out where it all started and how it got transmitted to humans. The virus is a very small lipid droplet that contains a single-stranded RNA, and it has multiple proteins, both in the capsid and in the membrane, the envelope. Maybe the most notorious is the spike glycoprotein. This is the protein that gives the virus the appearance of a crown on electron microscopy, as you can see in the image on the left. Hence the name coronavirus. Corona means crown. This spike glycoprotein contains the amino acid sequence that allows the virus to bind to the target cell. And so it's important in the pathogenesis of the COVID illness. The virus is primarily transmitted via respiratory droplets and aerosols. The viral particles can remain suspended in air for up to 3 hours. Fomite transmission has also been found to be a significant modality for the virus to produce contamination. In an in vitro study, the virus particles were found to be alive up to 28 days on certain non-porous surfaces, such as glass and stainless steel. These experiments were conducted in the dark and at low temperatures because the virus is very susceptible to UV light as well as elevated temperatures. Now, importantly, the virus can be eliminated with lipid solvents, namely soap, ethanol at a concentration above 70% per volume, as well as chlorine-containing disinfectants such as Lysol and the Clorox, but it is not susceptible to chlorhexidine, or Chloroprep, which is a very commonly used skin disinfectant during surgeries. The most interesting aspect of this disease, if I may say so, is the fact that it's very, very highly variable. 70% of patients have no or mild symptoms, and these mild symptoms can include headache, nasal congestion, sneezing, runny nose, etc. Things that you would expect with a simple upper respiratory tract infection. However, 30% of the patients develop moderate to severe symptoms, including ARDS, sepsis, and multi-organ failure. And the many organs that are affected are the lungs, the GI tract, the kidneys, and the cardiovascular system. The virus is able to get into the target cell via an accessory receptor, which is the ACE2 receptor. Once the spike protein binds to the ACE2 receptor, it is internalized into the target cell. It hijacks the cellular machinery to produce a copy of its RNA as well as its proteins, and ultimately multiple viral particles are released from that cell and are available to infect other cells and organs. The distribution of the ACE2 receptor has been studied extensively in histopathological studies, and it is very highly expressed in alveolar epithelial cells, and hence explaining the propensity for the virus to cause pulmonary diseases. It is also present in enterocytes, renal tubular cells, and in endothelial and smooth muscle cells in the vasculature. Notice here that I did not say that ACE2 was present in cardiac myocytes, and that is going to be very important in the way we look and interpret the data going forward. The cardiac complications that are seen in patients infected with the coronavirus include myocardial infarctions, myopericarditis, pulmonary thromboemboli, the Takotsubo stress cardiomyopathy, as well as cardiac arrhythmias. The pathogenesis is complex, but includes a heightened prothrombotic state, as Dr. Brantley talked about, a heightened inflammatory state, and of course, an increase in mismatch between the cardiac work and the blood supply. Congestive heart failure and LV dysfunction has been reported quite commonly in COVID-infected patients. One of the challenges was, or one of the questions that needed to be answered was whether COVID or the virus itself was causing direct cardiac injury or whether it was just simply unmasking pre-existing cardiac disease. And so the Mayo Clinic looked at 179 hospitalized COVID patients. These were severely ill patients, as evidenced by the fact that 61% of them were in ICU, 36% required mechanical ventilation, and 24% were on pressors and or ECMO. 15% died at 30 days, and 24% of them remained hospitalized past that period of time. A full 16% of these patients on transthoracic echocardiography had evidence of LV dysfunction with an EF less than 50%, and 31 of them had evidence of RV dilatation and some degree of RV systolic dysfunction. All these patients, or I should say the majority of these patients, had pre-existing echocardiograms that had been performed prior to them being admitted with COVID. And what was seen is that 78% of these people had abnormalities on their TEE, on their TTE prior to that hospitalization. In fact, 67% of COVID patients who had LV dysfunction carried that diagnosis prior to the infection. So in other words, COVID is not just producing a new disease, it's just allowing us to see patients who had prior cardiac disease that had either been unrecognized or not fully diagnosed. COVID also has been linked to elevations in troponin levels. As you know, troponin is a biochemical marker of cardiomyocyte injury. This is because of myocardial infarctions, of course, including acute coronary syndrome, such as ST segment and non-ST segment elevation infarcts due to a heightened prothrombotic state. These troponin elevations can also be seen because of secondary MIs or stress ischemia. They are seen in patients with COVID who develop acute PE and RV strain, but are also seen in cases of myopericarditis. These are patients who develop a decrease in LV function with a rise in cardiac troponin without evidence of acute coronary ischemia. And what is interesting about these cases of myopericarditis is that most of them are actually fairly mild. And when you look on MRI, there is no clear evidence of myocardial necrosis or scar formation. And autopsy studies have shown that the viral particles are actually not present in cardiac myocytes. There is very rare myocardial necrosis, and the virus is primarily present in the interstitium. And in 10% of patients who also develop concomitant pericarditis with evidence of pericardial fluid accumulation, the fluid itself is exudative but sterile. So the point I'm trying to make is that COVID does not seem to have a direct impact on cardiac myocytes. And the process that we are seeing is due to a form of inflammation, and the virus is present primarily in the interstitium as well as in the vasculature, the coronary vasculature. So keeping in mind this broad spectrum of cardiac structural diseases that COVID can cause, I want to try to focus now on cardiac arrhythmias, which is really the main reason why I'm here. So the first reports were from Wuhan, China, as you would expect. These investigators reported a 17% incidence of cardiac arrhythmias in COVID hospitalized patients. Of course, the incidence was much higher in ICU patients at about 44%. The problem with these early studies is that all of them were single center studies, and the data was not granular. So when they reported cardiac arrhythmias, it wasn't really clear what they were talking about. And in fact, it almost seemed that in some of these studies, they included sinus tachycardia in the diagnosis of cardiac arrhythmias, which in effect is not something that we would consider to be a serious problem. A more enlightening study came out of the University of Pennsylvania. They looked at 700 consecutive patients admitted with COVID-19 who were in the hospital between March and May 2020. Now, this wasn't a particularly high-risk population. 11% of them only were in ICU. The overall mortality at 2.5 months was about 4%. Of course, the ICU mortality was much higher at about 20%. What was interesting is that only 1.2% of patients suffered a cardiac arrest. And the majority of these cardiac arrests were due to PEA and asystole. There was only one episode of torsade de pointe. Atrial fibrillation was the most common arrhythmia diagnosed in that population at 3.5%. Bradyarrhythmias were quite uncommon at 1.3%. There were 10 cases of non-sustained VT and no single episode of VT or VF. ICU stay was the biggest predictor of serious cardiac arrhythmias. In fact, as I just mentioned, all cardiac arrests only happened in ICU patients. No patient on the floor arrested, even when they were diagnosed with the infection. Atrial fibrillation was significantly more common in the ICU patient population, as was non-sustained VT. On the other hand, bradyarrhythmias were quite uncommon in general, but they were kind of evenly distributed, if you will, between floor patients and ICU patients. So looking specifically at AFib, do we think that this arrhythmia is something peculiar to COVID? Is COVID causing more AFib, or is it just that we're seeing AFib because the disease is pretty serious? The inflammatory status is pretty high. This question was answered by a multi-center study from the Mount Sinai Hospital System in New York. They looked at COVID patients that were hospitalized between February and April 2020 and compared them to a population of influenza patients who were admitted between 2017 and 2020. So in the COVID patients, they had about close to 4,000 patients. 10% of them were diagnosed with AFib, but the overwhelming majority of those patients had already AFib that was pre-diagnosed prior to them developing COVID. So only 4% had a new diagnosis of the arrhythmia. In the influenza patient population, the overall incidence of AFib was also similar. It was 13%, and the incidence of new AFib cases was almost exactly the same as in the COVID population at 4%. So this data strongly suggests that there is nothing special about COVID and AFib, and that the disease is manifesting because of the arrhythmia is manifesting just because of the severity of the disease itself. Now, in both the COVID and the influenza cohorts, the overall AFib cases were more common in older patients with other comorbidities such as diabetes, hypertension, pre-existing cardiovascular disease, and these are the usual suspects that have been clearly established in prior epidemiological studies to be risk factors for atrial fibrillation. New onset AFib, however, was very peculiar. It was predicted, if you will, by the inflammatory state. So patients with a higher CRP and IL-6 level were more likely to develop AFib. It was also predicted by myocardial injury with correlation with troponin T levels. And AFib was much more common in patients who were intubated and those receiving glucocorticoids, of course, reflecting a more severe patient population. Now, AFib increased mortality by 78% in both the influenza population as well as the COVID population. Turning our attention to malignant ventricular arrhythmias, here again we start with data from Wuhan, China, with 187 patients who were admitted between January and February 2020. A third of them roughly had an elevated troponin T level, suggesting myocardial injury. That troponin T level correlated with the severity of the coagulopathy as well as ultimate mortality. Malignant ventricular arrhythmias was seen in about 7% of the patients, and they were much more common in patients who had elevated troponin levels than in those who did not have an elevation in that level. But what this study did not answer is what is the mechanism of ventricular arrhythmias in the COVID population? Is it similar to AFib in the sense that it's just a sicker population because of the nature of the disease, or is it because there is direct myocardial damage from the virus itself? This was looked at in the retrospective analysis of 140 patients hospitalized in New York between March and April of 2020. This was a pretty high-risk patient population with about half of them having evidence of cardiac injury by troponin levels. VT and VF were diagnosed in 9% of the patients, and almost every single one of them died. Overall, 88% of all deaths were non-cardiovascular, and the rhythm at the time of death was overwhelmingly a electromechanical dissociation, or PEA. 12% of the deaths were cardiovascular, and the majority of those were due to pump failure or acute myocardial infarction. So the rhythm at the time of death was VF, but it was in effect a secondary problem. The VF was not a primary arrhythmic event. It was secondary to the pump failure or to the occurrence of an acute myocardial infarction. And it occurred in the setting of severe metabolic abnormalities as well as an elevated vasopressor requirement. And as I said, this is very likely indicative of a secondary arrhythmic event. Serious cardiac bradyarrhythmias are extremely uncommon in the COVID population. An Italian study of high-risk patients in April 2020 included 30 cases. They had a mean age of 75, so that's an elderly patient population at high risk. The mortality rate was pretty high at 27%. 40% of them had a new arrhythmia diagnosis, mostly driven by AFib. There was no single episode of bradyarrhythmias, not one. In the 140 patient study from the Mount Sinai Hospital I referenced earlier, there were only 5 patients who developed complete AV block. That's an incidence of about 3.6%. 2 occurred in the context of a STEMI, 2 in the context of severe sepsis, organ failure, and metabolic abnormalities, and 1 in the context of a non-STEMI and the severe pre-existing LV dysfunction. The etiology of bradyarrhythmias in the context of COVID-19 is very hard to pinpoint because these are usually very sick patients and there are multiple mechanisms at play there. So you have vaguely mediated bradyarrhythmias that can occur because of lung hyperinflation, pulmonary toileting and suctioning, abdominal distension and pain. You can have bradyarrhythmias develop as a result of severe metabolic derangements such as acidosis, hyperkalemia, and hypoxia, as well as a result of ischemic events such as STEMIs, say of the RCA, as well as myocarditis and local tissue damage that affect the conduction system in the cardiac tissue. Moreover, remember that critically ill patients who suffer from COVID are typically elderly, and it's very, very likely that many of them have pre-existing cardiac disease, including a higher prevalence of baseline conduction system disease that becomes unmasked when they develop the virus. So we talked about the impact of COVID-19 on arrhythmias in hospitalized patients. Do we have any data on the impact of COVID-19 on out-of-hospital cardiac arrhythmias? The data that I found primarily relates to out-of-hospital cardiac arrests. And so a nice study from Italy looked at out-of-hospital cardiac arrests between February and March 2020 and compared that data to the out-of-hospital cardiac arrests that occurred in the same period in 2019, predating the COVID-19 epidemic. And as you can see in the blue bars, which represent the cardiac arrests in the COVID era, these bars are significantly higher than the orange bars that represent the cardiac arrests prior to COVID for the same time period in February. So clearly there is an impact of COVID on out-of-hospital cardiac arrest. And much more interestingly, if you look at the cumulative cases in that orange line, this is the cumulative cases of COVID-19 patients, you will see that the slope matches the slope of the out-of-hospital cardiac arrest. So there is some kind of correlation between the incidence of COVID-19 and the occurrence of out-of-hospital cardiac arrest. Now, this does not necessarily imply causality. It doesn't mean that COVID-19 is directly responsible for out-of-hospital cardiac arrest. There are multiple reasons that one could invoke, including the fact that, as you all know from your own practices, during the height of the pandemic, a lot of patients were afraid to come and visit with their primary care physician or their cardiologists, and so they were delaying their health care. Moreover, patients who developed symptoms that we would consider to be heralding of a catastrophic event were thinking twice about presenting to the emergency room from fear of contracting the virus in the emergency room. And of course, there is always a possibility that there's some unmeasurable direct impact of the disease on cardiac myocytes that led to these out-of-hospital cardiac arrests. Now, I would be remiss if I did not tackle the topic of drug-induced cardiac arrhythmias. As you well know, there are multiple drugs that were advocated for use in the treatment of COVID-19 that are well known to be pro-arrhythmic. Prime amongst them is hydroxychloroquine, especially in combination with azithromycin, but also remdesivir, which was approved early on by the FDA to be effective in moderate cases of COVID-19, can also lead to QT prolongation. It can also lead to significant bradyarrhythmias. The antiretroviral combination lopinavir and ritonavir can lead to bradyarrhythmias, as do Precedex and propofol, both of which are used for sedation for patients who are ventilated. Now, of course, when we do our rounds and we are trying to decide on an antiarrhythmic drug to use in a COVID-19 patient, we have to be very mindful of what medications they are already on, because we can cause antiarrhythmic drugs to become pro-arrhythmic if we use them in the wrong environment. If there is another medication that can prolong the QT interval, amiodarone or sotalol or Malta can become, in effect, pro-arrhythmic. The complexity of the management of the COVID-19 patient is further enhanced, if I may say so, by a number of logistical factors. It is very difficult to transport COVID patients out of their own units because we have a fear that we may contaminate other patients, other units. And we want to limit the exposure of the healthcare staff to high-risk procedures. For example, TEEs can cause aerosolization of the viral particles that may ultimately lead to the nursing staff or the physician staff becoming infected. So if patients have atrial fibrillation and are COVID positive, and we want to go ahead and perform an evaluation of the left atrial appendage for clots in preparation for a cardioversion, we may decide not to go for a CT scan instead of a transesophageal echocardiogram because we reduce the risk of particle aerosolization. Of course, patients who are in the ICU and who have COVID-19 have multiple cannulas in place in the venous system, including the ECMO cannulas, triple lumen catheters, cardiac monitoring, hemodynamic monitoring cannulas, etc. So we are very mindful not to invade their vasculature if we can avoid it. So patients who have bradyarrhythmias and have COVID-19, we try as much as we can to delay the placement of transvenous temporary pacing wires, and we try IV medications such as isopril or dopamine to see if we can reverse the bradyarrhythmia. Of course, I mentioned earlier the challenge of choosing antiarrhythmic drugs in that patient population because of them being in other medications that could interact with these antiarrhythmic drugs and make them dangerous. And there is the challenge of conflicting therapies. You know, if somebody has atrial fibrillation and they're in ICU, they may be prothrombotic, and we are worried about them developing a stroke because of AFib. Our tendency would be, or our preference would be, to start anticoagulation, but at the same time, these patients may have multi-organ failure and maybe have low platelet counts and may be at risk for bleeding. So making a decision as to whether anticoagulation is warranted or not becomes particularly complex. In conclusion, our understanding of COVID-19 is evolving and the story is being written as it unfolds. You know, in the fog of war, the science has become very difficult to interpret because there are multiple small cohort studies with poor quality data that are being reported and published. There are many questions that remain unanswered as to the origin of the virus, you know, how it spread, how we're going to get rid of it, how to avoid another pandemic, and how to best treat it. And the science, however, at this point does not support a direct pro-arrhythmic effect of the SARS-CoV-2 virus. The observed and reported arrhythmias seem to be a reflection of a virus non-specific response to the inflammation and the prothrombotic milieu that the patients suffer from. And I appreciate your attention.
I'm pleased today to bring a brief summary of the presentation you've just watched on the cardiac arrhythmias associated with COVID-19. The cardiac complications of COVID-19 are numerous and include myocarditis, reduced left ventricular ejection fraction including heart failure, left atrial enlargement, right ventricular dilation, pericardial infusion, and of course myocardial infarction from thromboembolism. We see common lab findings in patients with myocardial complications of COVID-19, almost always increased troponin levels, and we see the usual cardiac arrhythmia complications associated with non-COVID related heart conditions, including cardiac arrest, atrial fibrillation, bradyarrhythmias, and ventricular tachycardia. Much has been studied about the management of arrhythmias in patients with COVID-19, and generally, as you heard in the presentation today, the same approaches that we take in non-COVID patients to manage these arrhythmias as they arise with cardiac complications of COVID-19 should be used. So use your guidelines for management of these cardiac arrhythmias. So as you continue to care for your patients with COVID-19, I know you'll use your clinical judgment to make the best decisions for them, and we wish you well in the care of your patients. Thank you so much.
Greetings, my name is Dr. Charlie Sands, and I serve as chair of MedEd Global's advisory board. As an international medical education service provider, MedEd Global is excited to have provided this outstanding review of the cardiovascular complications of COVID. Our mission is to promote superior education and training for international healthcare personnel. I sincerely hope that this educational video has proven to be of help to you and your colleagues. If you'd like to discuss ways in which you can support or become a part of MedEd Global, our contact information will appear on the screen momentarily. Thank you for the opportunity to share this important information on the cardiovascular complications of COVID.